Okay, we're recording. We finished bones, and what would be next are joints. Joints carry over from an exam perspective. They will be on the next exam. So, and it's another one of those chapters like bones, where we do a little. I mean, it's both anatomy and physiology because it just lends. It's not that much physiology vis-a-vis joint. It's more about with joints. It's about what goes wrong, not so much as to understanding the mechanics thereof or anything like that. So I'm not going to get spending a great deal of time with that. So again, the first misnomer is the idea that, or not misnomer is the wrong term. The first misconception is it's a joint, it's got to move. Well, a great many of your joints don't move at all or move very, very limitedly. So when most of us, when you're talking about joints, you're talking about freely movable joints, which you do have, which are obviously very important. But a joint by definition or articulation, when you see the skeleton set up in the lab, and we have a new one that's going to be set up shortly with everything there, it's called an articulated skeleton. So joints are articulations, and you kind of get that ART with the arthro type of suffix indicating, referring to a joint. That's there. So as long as two bones meet, you're there. And yeah, they hold things together. Mobility is sort of implicit. And there are three both structural and functional classifications that are very, very easy to discern. The fibrous joints are the ones that move the least. The cartilaginous joints, limitedly, and the synovial joint, the classic joint, when you think about joint fluid or a joint enclosure and the advent of most types of arthritis, is the synovial joint. So that's the structural classification, and we'll see the ingredients in each of these that are there. The functional classification is used as well. And again, when we look the term arthroses, again, that the implication is joint-related phenomena, conditions of, and oces is a condition of, is how it is. So when someone has an arthrosis, they have a particular condition of a joint. Syn, without. So immovable or effectively immobile joints. Amphi, some, slightly movable, and diarthroses, I don't know how the derivation of that word is, where the prefix is, but it is freely movable joints. So synarthroses are mostly fibrous, amphiarthroses are mostly cartilaginous in nature, and diarthroses are the freely movable ones. The only ones that have a true joint cavity, the last, synovial or diarthroses. So when we're talking about synovitis, we're talking about arthritis for the most part that I have, and particularly unpleasant today, having had a number of manipulations by my family chiropractor. Thanks very much, Dr. Dave. So fibrous, we'll start. We'll get the easy part out of the way. So they're joined, as you would suspect, by dense fibrous tissue. It goes back to what we talked about in lab. The sutures. The sutures are connected by fibers. As those fibers shorten, they pull the bones together, and effectively they become immobile. So as the bones enlarge and the fibers contract, there is no joint cavity. They are early on. Again, those are the soft spots that we see in the child's skull when the child is born. So there's inherently a little amount of give. That's because the fibers are longer. And we classify them interestingly, and there's a fair amount of sport that goes on with this. Sutures, the ones we looked at, syndesmoses. A syndesmosis is a very interesting name. And you're going to see syndesmoses, and this will get you into the very famous distinction that a lot of people are unfamiliar with between the typical ankle sprain, what they now tend to call an ordinary ankle sprain, C1 Saquon Barkley for the Giants, versus the nefarious high ankle sprain. I'll tell you about it. And then gomphoses, think gum. That's the socket. So there's a ligament, the periodontal ligament, that's holding your tooth into the socket. And indeed, when you have to extract a tooth, the idea is that's really the rate determining step, being able to snip that and free that ligament so you can yank the tooth. So sutures, rigid interlocking joints, growth and use, connective tissue fibers allow for expansion. Over time, they ossify, they become truly bone, okay, and fuse. Uh, Obviously protects the brain. When we see the transition, it's a name that you may see down the road, called synostoses. That's the transition between the fibers to the bony. There are a number of areas where abnormally we see bone to bone fusions that preclude motion. The most famous of these is in the foot. Okay, it's called the tarsal coalition. When we look at the tarsal bars, it's where tarsal bones, it's as though two of them have a bony block that has somehow frozen, and it causes a particular kind of foot spasm. That's fairly, it's less common. It's more common than you think, which means I used to see one or two of them a year that are there. And so that's another term where we'll see a synostoses, where it may have started as fibers and became bone at some juncture. So it's a typical sutural line. There's the fibrous connective tissue. It compresses, shrinks, whatever terms you want to use, contracts, and it matures. I just think it's more of the bone growing together, and the fiber is not necessarily, because inherently these are not stretchy kind of fibers. There's a certain amount of give just because fibers are there. Bones connected by ligaments, bands of fibrous tissue. So it's the same as what I was telling you about before. So because there's variation, there's varying kinds of movement. This is the very famous one. You'll see it shortly. That's associated with what is known as a high ankle sprain, the inferior tibiofibular joint. The tibia and fibula, as well as the radius and ulna, when we get into the bones, are connected by something called the interosseous membrane. It has a certain amount of give. We could very well do this, a lot more in the upper extremity than in the lower extremity. That band of fibrous tissue gives origin and attachment to a lot of muscular structures. Okay, so it's an anchoring point. There's a lot of these sort of hybrid, dense, might be ligament, might be tendon kind of structures that we see. Now, the bones themselves are held together rather securely, much less so in the wrist than they are at the area of the ankle, and you'll see the illustration shortly. So it is technically a joint. There's one in the upper portion and there's one in the lower portion, superior and inferior in the case of the tibia and fibula, or proximal and distal, because it's a little bit easier because your arms kind of like, think anatomical position. You could say superior and inferior, but proximal and distal, I think, lend themselves more to it. Okay, and so the interosseous membrane here, like I said, allows for a fair amount of motion. This is that joint that I was talking about. It's a rather distinct ligament. So what occasions you to twist an ankle, there's different things. The big player, again, pardon my poor artwork. Here's fibula, here, much larger, it's tibia. They sit on top of the true ankle bone, which is called a talus. Tibia, fibula. When you twist an ankle, depending on the position, this or this, the dome of that bone, and it is very much dome shaped, will whack into one of these depending on the angle. Okay? And that can make that ligament pop. Most of the time, ankle sprains, because your heel bone down here is called the calcaneus. Most of the time on the outer ankles, a typical ankle sprain is what we call an inversion sprain. You walk in, you chuck hole, and boom, goes over. We've all done it. Okay. And what happens is there's three ligaments down here, one forward, one backward, one kind of in the middle, that basically come from the fibula and attach somewhere in and around the talus or the calcaneus that are there. So normally that's where the damage is. Depending on the force, the location, the twist in the bone, all those interesting factors, it can pop that, and that will cause a split. Okay, fancy name for the split, diastasis. Pronounced sometimes diastasis. And so years ago, before the advent of and the common usage of MRI technology, which has probably only been around and employed a lot in the last 40 years. So prior to that, maybe even 35 years. Prior to that, okay, we had to do what's called an arthrography. So you would take x-rays and you would inject into the joint, an iodine-based compound into the joint that would be radio opaque. And if it was contained within the ankle joint, well, that was probably a lower or ordinary ankle sprain. But if the fluid went up where that in the ligament, sort of in between this area, you had the high ankle sprain. There's a lot of techniques that they use today that are different. We're able to tether them together. In our day, we would put what's called a transfixation screw. So it would be a screw that went across through the tibia here, and into the fibula, but not all the way over. That's what we used to do for that. That in lieu of the typical 3-week ankle sprain for somebody, even a high level output. There's some rumor he may play Thursday night, Saquon Barkley. I'd be surprised. Wouldn't be shocked, but I'd be surprised. And on the other hand, these are that 6 to 8 week kind of recovery. They're much longer, and a lot of times they can be a season-ending injury. Just to give you some idea, it depends on how stable the structure is supposed to be. There's a ligament that goes all the way up that you'll see when we start looking at the extremity bones, again, called the interosseous ligament, that really this is maybe the last extension of, that doesn't move a great deal. It secures them together. If anything, it creates compartments. We'll talk about that with muscle. And then lastly, the gomphosis, peg and hole, whatever you want to call it, teeth, alveolar sockets. The alveolar sockets are those indentations where the teeth form, the periodontal ligament. I don't do teeth. That's as much teeth you'll get out of me. Not a teeth person. Okay? So all of that jazz that you see in there, and but if you're like me and have had a gazillion extractions, unfortunately, it's just a joy digging around in there. Which brings us to, those are the fibrous ones. Now we have the cartilaginous ones. Yeah, I understand when baby teeth come in and secondary baby teeth go out and loosen, effectively what's happening, the new ones are growing in and they're sort of creating that ability for that tooth to loosen and be relatively easy removed, you know. And of course, you know what you do with it. Tooth fairy. Just saying. And poker has really gone up with my kids. My grade. Boy, when I was a kid, nickels and dimes, you're lucky. Now it's folding money. I'm telling you. So, moving on. So these are cartilaginous joints, amphiarthrotic, some movement. Like fibrous, no joint cavity need apply. Not a lot of motion. Basically two. The synchondrosis and the symphysis. The synchondroses, I don't necessarily buy what they're selling. They talk about that epiphyseal plate, the joint plate, as being kind of a joint. I don't buy it. Now, if you're going to tell me there's some mobility in it, I might buy that. Okay, but I think there's very little. I really don't necessarily. I think that's an anatomical, not a functional classification. And yes, and if you want to make a point out of it, when they formed that epiphyseal line, now it's all bone, and who cares? Okay, the cartilage of the first rib with the manubrium of the sternum. That's really important because that's that part here. All you do is palpate your sternum. Go either side, you'll feel a big bump. That is the area where you get something called the sternoclavicular joint, and immediately near that is where the rib attaches as well. That's a lot of motion that's facilitated by that. There's also a cartilaginous disc within that joint because your upper extremity, I say it time and time again, is all about, it's a trade-off. You have extraordinary degree of mobility, but you have an extraordinary degree of instability. So it's easy for that to be, and we see the injuries all the time with pectoral muscle tears and triceps muscle tears. They're very, very common. Okay. Biceps tendon tear, and we'll talk about all those because I have a lot of information to share with you in this particular unit. So we'll get more about that. So they're talking about this. I don't necessarily buy it. They're talking a little bit about this. See, the clavicle would be up here. That's where the sternoclavicular joint, and that's actually a moving joint. But apparently this is designed to have contribute a certain amount of motion. Symphyses are much more common because they're the ones that are associated with, and we looked at them in lab, cartilaginous discs between bones. No joint space, so some type of cartilage is there. In this case, it's fibrocartilage. It may have some hyaline component, but it's mostly fibrocartilage, very, very strong, minimal motion in between the vertebrae, all up and down the vertebral column. And the most interesting one is the symphysis pubis. The two bones that make up the anterior part of your pelvic area are called pubic bones. They're all fused together with the other bones, the ilium and the ischium, that make up the os coxa, or hip bone. But anteriorly, there's a pad. And there's some motion in there, which certainly be very, very useful when it increases during the time of a vaginal delivery. To give you some idea. So that's an interesting area, the symphysis pubis. So here they are, intervertebral disc. We talked a little bit about the nucleus pulposus and the annulus fibrosus. A lot of ligamentous structure. These are those these are the intervertebral openings or foramina. Here, this is what I was telling you about. Here's the sacrum. Here's the ilium. Down here, big thick part in the bottom. You're all sitting on is the ischium. The pubis is maybe this much bone. And here you can see the symphysis pubis between them. And we'll make a very interesting study of this area. That's called the pubic arch. That's one of the key areas forensically where we distinguish between men and women if all we have are a bone or two to deal with, or bone fragment, because you can extrapolate from that. That's it. That's the partially movable and the immovable. Now we get to the fun stuff. The ones that move. Synovial or diarthrotic joint. Some people will, there's different names. You're going to see there's 6 different subcategories of these joints. You'll need to know an example from each category. They're not all simple hinges. Some of them have a great deal of rotation. Some have minimal rotation. Some slip and slide. Some pivot completely. There's a lot of nuances that you will see here. Okay, by definition, freely movable. Almost all the limb joints, I'll buy that. And I take some issue with this. Now understand, anatomists write these textbooks. It's most of them don't have a lot of experience evaluating people for sport-related injuries or other types of ambulatory injuries, etc. Which is what I do, or did. So we have a fluid-filled cavity. They're freely movable. They'll get to the general features. Many of them, not a ton, have additional bits of synovial material, either wrapped around tendons or like little pads to keep things from rubbing against one another. And sometimes, and many of them are there, you're born with them, some develop. Okay? We have stability, and this is where I take issue with some of the factors. We'll talk about the movements, and we'll talk about the 6 different classifications. So here are the features. Number 1 in the hit parade, the ends of the bone, because it was all a cartilaginous shell for the most part, have cartilage called hyaline cartilage, because the bone was originally hyaline cartilage. The only hyaline cartilage that's left after the growth plates are done and have effectively fused or ended and become all bone is the articular cartilage at the ends of the bone. I don't buy at all that it stops crushing. Not in the least. Okay. It's about 1/8 of an inch thick. I mean, if you jump from a height, it's not going to stop the bone from crushing. Trust me, it just doesn't work that way. You'll hurt the cartilage, then you'll hurt the bone. So the notion that that's there is already odd. Okay. It's thinner than you think. Okay. But interestingly enough, when we look at these bony surfaces, okay, like the head of a femur or something like that, you are looking at, so I mean, I'll just sort of generically, here's a neck, here's a head like that. This is covered by a very, very thin layer of material that's articulated. Or even if you're looking at something, if we go down and look at the bottom of the femur, the inferior femoral condyles that are there, the cartilage is sort of, it occupies more space than you think, not just in this 2-dimensional drawing, but also forwards and backwards. So it's a little bit more than you would think, but it's not terribly thick. It's beautiful, it's white, it's glistening when it's healthy. When it's not healthy, it's very distinctive. It's pockmarked, it's either very hard or very soft, and it's irregular. It looks awful. That's the distinction between an arthritic joint and a normal looking joint. Why would you go into a normal looking joint? Because sometimes you have to reposition a bone. Okay. And you have to open up the joint to access it, because when you're changing the position of the bone, the joint surface becomes an important reference point, mechanically speaking. And we do a lot, and there's a lot of computer generated images. There's templating, which means you're drawing from x-rays or from other studies and trying to create the amount of bone that you have to take at what angle and how to reposition. So there's a lot of science behind that as well. So it's sort of like the paper doll, basically template. That's right. I just think of my wife with all those the dress patterns and things like that. So she could be working on goose clothes today. So those are geese you can interact with. Geese that are in the wild, stay away from. They're not pleasant. If you haven't noticed that, they're not. Oh, I want to go pet the goose. No, they're unpleasant. Honkers. So, synovial cavity. It has fluid in it. The fluid has been referred to as synovial fluid or joint fluid. It is slightly viscous. Okay, it has enough protein in it to give it a certain amount of viscosity, like a very, if you will, a very lightweight motor oil would probably be how you would look at it. And interestingly, when we're looking at joints and evaluating them, we evaluate the fluid. When we take it out, you put a drop on your gloves, see how stringy it is, how much it pulls apart. That's like there's all sorts of tests that you do associated with it. It gives you a clue, a clinical clue. So when they talk about a potential space, the space is there. It's not always filled and it's not always empty, but there is distinctly a space. Sometimes you have stuff in the space. That's when we start talking about specific joints like the knee, or the temporomandibular joint, or the external clavicular joint, where you have extra cartilage in there that increases its mobility. That's the good news. The bad news is more stuff to go wrong. So it's anytime you have something, when you increase the complexity, unfortunately, if something goes wrong, it makes it a lot more difficult to fix. So sometimes, it's the old story, KISS, keep it simple, stupid. It works. Okay. So what's the cap? So to give you a generic view of a joint that I signed bad art. It's funny, my daughter is great with this. She started at the Late Art Institute here in Pittsburgh, Lodi's, many years ago. She looks at a room and she sees color and things that she can do with it. She left there in about 6 weeks and said, "What's up?" She goes, "Half the people are stoned and half the people are crazy." That was her evaluation. But she hasn't lost the ability. She's very creative. So it looks a little bit like that. Let's say you're looking at a finger or a toe. That's about how it would look. You have like a ball-like head, and you have a nice size socket. I'm trying to represent something called the condyloid joint. So it's very, very convex and very, very complex. That's there. So what do we have? We have dense, irregular connective tissue. That's what capsules are made of. They're quite thick. So if you drew it, it would be this kind of thick. The interior lining is simple squamous. Okay? So and what it does is secretes the fluid. So you have the external fibrous layer that gives it its strength, and its internal or inner synovial membrane, which is loose connective tissue, and sitting upon it are the synovium or the synovial cells. Synovial cells are busy cells. If they end up with any tumor in there, by definition called a synovioma, is always malignant. Those lining cells are very unique and interesting. And I don't know whether you did this when you were in micro, But the lining cells in joints and the lining cells in your heart and around heart valves are very similar. They're simple squamous epithelium. And they're both affected by the same disease, which is a complication of something that's relatively routine called a strep throat. And that's what rheumatic fever comes from. The rheumatic has to do with the joints becoming inflamed. And the fever is just the immunological response. But it also, not only does it damage joints, it also damages, and very significantly, more so than the joint, heart valves. It's one of the more common, certainly as common as any reason for infectious disease involving heart valves. I don't know whether you got that presented to you or not, but that was, after the measles, that was the number one fever and rash disease pre-antibiotics. We did them by number. 1, 2, 3, 4, 5, 6. We have a disease that's called Fifth's disease. That children, it has to do with, of all things, caused by a parvovirus, which is usually something dogs get, kennel cough and things like that. But children get, it's called slap cheek syndrome. So it's about the fifth most common, so they named it Fifth's disease. It's just like a red lacy pattern on the cheeks. All my kids have it. And of course, you know what they said. He hit me. Every time I get mad, I go 1-800 for a child. And now I told you I got him now. Come near me. Elder abuse. 1-800 elder abuse. I'm having a great moment. Do that. Wait till you're old enough. Do that to your kids and grandkids. Tell them in life what goes around comes around. Or as our Klingon friends say, revenge is a dish served cold. Synovial fluid. Viscous, slippery, mostly plasma. The addition, this is where you see a lot of people, I'm one of them, over the years have taken a fair amount of supplements in the form of hyaluronic acid, okay? MSM with hyaluronic acid, chondroitin. It's the kind of stuff that plays a big role in cartilage and joints. So yeah, does it lubricate and nourish? I'll buy that. There's a lot of phagocytic cells. This is a sterile environment. It's the difference between when we do an endoscopy looking in somebody's stomach for an ulcer versus doing an arthroscopy into a joint looking to see if there is a torn cartilage. That's a sterile procedure. The procedure when you look in, and immediately as soon as you put the tube in there, it's no longer sterile. It's not a sterile environment. And different kinds of ligament. The interesting thing about the knee, it's got all three. It has capsular ligaments that are part of the fibrous layer. You dissect them, you'll see them distinctly incorporated into the capsule. Ones that are outside that are actually, you can find a space between them and the capsule. And most famously, ones that are inside the capsule that have their own synovium, very famously the cruciate ligaments. So you've got a lot going on, and that's what I mean by layers of complexity. And then nerves and blood vessels, certainly joint position sense, blood vessel capillary supply, better than my illustration. It gives you an idea of the extent. Because again, if you're going to take an elbow, it's got to be able to bend this way. And again, it fan folds. So the interior of the joint forms little, almost the appearance of closing the drapes. That type of a thing, almost those accordion pleats. And indeed, that's one of the problems we see in sport when one of those pleats folds the wrong way. And the name that we give it is called a plica, because pleats are technically plications. So when you have a plica in your knee, it's a sport injury where rather than fan folding the way it's supposed to, one folds kind of backwards, it gets stuck. And you have to do something about those a lot. Sometimes you just have to exercise. My first wife got one of those. She was doing a lot of ballet type stuff. And she's very into the dance type of stuff. And so what I'm saying is the extent, the joint isn't just relatively flat or just covers a part. It goes a lot farther than you would think around the head or around the base, if you want to consider those things. And it's continuous with that lining on the bone that I spent so much time telling you about, the periosteum. So the periosteum is adherent to the bone once it makes a transition to capsule, and it's very similar in the sense that it's dense, irregular connective tissue you begin to see that point of separation. So it was like a little pocket that's there, so we can identify that, particularly at the time of surgery. I didn't do it. I mean, I didn't operate every day, but almost 90% of the procedures I did were on bone and joint related procedures. Other things, fatty pads, cushioning, you see those in a number of areas. And here are the articular discs, also in the knee, not the only area. And effectively, what it does is it increases frequently range of motion, what we call degrees of freedom. Does it contribute to stability? Somewhat, particularly when you look at the knee. The top of the tibia, what we call the tibia plafont, fancy term PLAFONT, that's relatively flat. Those gaskets of the menisci create a concave area for the rounded heads of the femur to articulate with. And it allows them not just to flex and extend, but also to rotate internally, which is extraordinarily important for walking, running, ambulation of any type that are there. A lot of these, they refer to them as ball bearings. It's pockets of lubrication. It's like if you got a sore heel, maybe you go over and get one of those Dr. Scholl's things and stick it in your heel. It'll be like a little gel pad or a gel insert. I mean, you could think of something like that, but these are inherently part of it. So they're not necessarily part of joints, but they're in there. And some are there all the time. The shoulder and the knee have many of them. The fancy term we give them is fixed, meaning that you're born with them, they're part of you. The ones that come because of a particular activity you're doing, and it's in an unusual or atypical place, are called adventitious. So you have fixed bursitis and adventitious bursitis. And some of them are very, very common. Your treatment isn't a whole lot different for them. And so the fluid, now every so often the fluid will be trapped in there, and that fluid, when it no longer has any circulation, will undergo a change, as you might suspect. And it changes from liquid almost to gel-like material. Okay, and that's the transition to a term that I'll probably talk about in passing because I'm doing it now, where we begin to see something forming what's called a cyst. A cyst is a fluid-filled sac that's usually an outpouching, like a bubble in the tire, coming out of a joint or coming out of a tendon sheath or one of these synovial items. And when the stalk gets walled off, now that fluid again changes into a more organized gel-like fashion. So they're not interchangeable terms. I've removed many of those. Typically, you remove them, you can snip them at the bottom, and then and basically oversew it. Not again, it's a sewing. She's coming back for a visit to the house down there, and wherever that is, like near Ohio Pile, the Silence of the Lambs house, the gal who played Catherine, who's been around for inches. There was a big article about that. So every time I think about sewing, I go, do you sew, Clarice? No Silence fans around here? See, that's what you're talking about. You know how much self-control I have with what I say. That would be none. Ever. Guy can be on there for 20 minutes and have a captivating performance. Yeah. I love it. He threw a little Truman Capote in there. He's got a very, very high-pitched voice, late wonderful author, did In Cold Blood. Was obscenely invested in murders and things like that. Just brilliant. And what happened was, so when that movie came out and was still very popular, I just started to teach. I was at La Roche. For whatever reason, a lot of the people who became professors, when they started adjuncting or part-time, they were at La Roche. A lot of them. And even the dean, Dean Kalovich, who's no longer the dean, has gone back to faculty. She started out adjuncting around up at BC3, Butler County Community College. So we all kind of got to start that way. And so I was trying to make a few extra bucks. And so they said, well, you can do some tutoring. $10, $15 an hour, nominal. And La Roche, who was in charge of the tutoring program? Sister Clarice. When I had to meet with her, I took all my self-control not to go, why, hello, Clarice. How are you? Which I figured would have gotten me out of it, so I was very polite. Wasn't like Whoopi Goldberg in Sister Act, but what do you do? Moving that. So moving tendon sheaths are like that. And I'm going to give you a clinical example why these are so darn important. Whenever a tendons are those leaders you can see, whether they're in your ankle, when you can feel behind your hamstrings, those are all tendons. When they go around a bend, particularly into your wrist or your ankle, they have a sheath. Okay. When we hear about a biceps tendon tear, it's not the tendon, it's the sheath that it's in, and we'll see that on the bone. It fits into a particular groove. And it's like what they call a super stabilizer, which is in this unit as well. To fix those, when we would do extremity surgery and have to lengthen a tendon or move a tendon, those tendons are such that they're under such pull that if you don't tag them, even if you cut them, before you cut them, you put a stitch in there with a hemostat and put it aside on the sterile field, because they can snap back, kind of like, bleeding the blinds. And if that happens, you got to go back in and find them and go in by way of the tendon sheath and pull them back through the tendon sheath so they don't work no more. You should say a mild neighborhood. So it's not easy. That's all the kind of stuff that over years of experience of working with people that you learn. There's a great saying in medicine, and it's true like it was, and it's in any healthcare field, it's in any field for that matter. It's called see one, do one, teach one. That's how you learn. You see somebody do it, they walk you through it doing it yourselves, now you show somebody else how to do it. And it works. Been around for a long time. So this is the one I was telling you about. That's the tendon sheath. It's like a flap of synovial membrane surrounding this tendon, which is called the long head of the biceps. It inserts all the way up here, and what you will learn is called the top of the glenoid fossa. And there's a glenoidal tubercle on top of that particular aspect of the scapula. And this is basically your shoulder joint. And it's not much of a joint from a standpoint of impressive, because there's not a lot of surface area. You have a relatively limited area. There's a gasket around it. It's called the labrum. And if you heard about someone with a torn labrum in their shoulder or hip, it's on both of those ball and socket joints. And what this is, of all the joints, the one that's held in mostly by soft tissue, muscles and tendons and ligaments, by far and away, the shoulder. Despite what this book would have you believe. So like I'm saying, if this tears, usually it doesn't tear, it usually ruptures the sheath and it pops out. You have to shove it back in and oversew. And there's a lot of athletic stories with that. Aaron Smith missed a long period of time when he was in the Steelers he was a defensive end on the last two Super Bowl. They do this and it gets pulled the other way around like that. That's an unusual. Ray Lewis had that injury. I think he had a triceps tear with the Ravens. And when Bill Cowher came to town, he had a running back who ran for like 1,600 yards and was like all pro, named Barry Foster. Okay, back in like 92, 93. He was just unbelievable. And he popped one of those, a similar one, but in his ankle. There was a whole try, and he was very reluctant to have it fixed surgery. He went to every surgeon, orthopedic surgeon in the city of Pittsburgh. The late Freddie Fu operated on. Most of the guys wouldn't touch him. I talked to a guy who I was not pals with, but we were in a dad's group together with our daughters, who was very famous from AGH. And they're like, I wouldn't touch him. In medicine, there's an old saying, call up your worst enemy, tell him or her what a great doctor they are, and refer him that patient. Only you could handle this. Take it, please. It's true. This is called the subacromial bursal sac. The acromion process, I talked about it a little bit. This is the acromioclavicular joint. Underneath it, there's always a bursal sac there, very often irritated. Maybe that, who knows, that clicking you were talking about might be related to that. Because a lot of, and as we were talking about it before, sounds don't indicate a problem. When I can't tell you how many people get up in the morning, go up and down the steps, and it's like, oh my God, the word. I can hear you in the morning. Good for you. It's the dog. Now, this is where I don't buy it. To me, the number one thing that that where you can predict stability and movement is right here. The shapes of the articular surface. Ligaments, not limited at all. Muscles, much less important. I can't tell you how many dissections we did and research we did back in the day where we would dissect the lower extremity and just leave ligaments and take off all the muscles, and a foot and leg would stand by itself. No muscles need apply. So where they get this frog in my throat. The frog? So it's so much as my dad used to say and my grandfather, donkey dust. Because they were polite back then, you didn't swear in front of your children like I did. I never heard my parents swear until I was 21, and after that I never heard them stop. They talked to us in Yiddish. They went back to the old country language. What are they saying? My sister and I look at each other. So voila, there you are. You can read through those as well as I can read them too. What I don't do is this. This is archaic and traditional. If you go to another school, okay, with a traditional teaching anatomists, they will do origins and insertion. Traditionally, from the larger or less mobile bone to the more mobile bone, the origin is on the less mobile area, typically more proximal or toward the torso or the larger portion. And the insertion is, and it's all baloney. We talk about attachments, superior and inferior, medial and lateral. I mean, you can move different ways. It depends on what you're doing. If I'm in the car and I'm going to hit the brakes, I'm going to plantar flex my foot. I'm going to push down like that. Okay, I'll buy that my calf muscle is firing, causing my foot to go down and push on the brake or the accelerator, depending on what I'm trying to achieve. But I'm short, vertically challenged. Okay? And if I got to get, my wife and I are both like that. We try to get something in the top shelf. What do? We get on our tippy toes. Doing the same thing. But it's not, and it depends on what part is moving. The foot is the fixed part, not the moving part. Me is the moving part. It's working backwards. It's like you can do curls with weights, or you can do a chin up. You can do a chin up. Okay. It's like I got a kid like that with, oh dear, I got to do 100 sit-ups and 100 push-ups every day and running, gosh, only knows. Military physical tests. That's why he ran marathons. So we won't talk about origin. We'll talk about attachments. And you can figure out once you know what they're attached to, you can figure it out. So does it cause the insertion to move through the origin? Sometimes. Is it planar? Yes. And we're going to see most of the time we can identify what planes it moves in. And then we'll talk about the different kinds that are there. Sometimes the tiny bones in your wrists, the tiny articulations in your torso, particularly in the vertebral area, are called non-axial. They shift and slide a little bit. They're just very hard to predict. But when you add them together, you get a substantial amount of movement. Uniaxial, one plane. Classically, you'll see the elbow. You look at the elbow itself, it's as close to a perfect hinge joint as there is. You'll see why. Biaxial, two planes. Look at the knee. It flexes and extends, but it does rotate internally. And multi-axial, only two. And those are hip and shoulder. And they basically, the motion is called circumduction. It means if you stabilize it, you could take your pinky or your index finger or your big toe and trace a circle. Your thumb doesn't quite do that, the opposability of the thumb. And then we'll look at the different motions, whether they're gliding, angular, or rotation. So we'll stop it there, pick the rest of this up on Friday, and continue us with this discussion. Thank you. Nice chatting.